The NEERS fracture classification is one of the most widely used system. Right now, NEERS system originally did not talk about these injuries, but over a period of time, with the modifications, we do see this, right? So in this, we can clearly see type 6, which is lying at the bottom. Those are the fracture dislocation, and you can actually see so many subtypes in them. Okay, so our focus is usually on one part, two part, three part, four part fractures, and these lower ones are actually not very well focused on. And then everything looks like a fracture dislocation, right? So this is where the confusion is. Now, if you look into this, each of these is a fracture dislocation. Okay, but how they behave, or rather how one can prognosticate them, is totally different. Now, example one, leftmost side, you have a fracture. The shaft is totally medialized. The GT looks to be fractured, but not totally displaced, right? If you see the second one, it looks very confusing, but the head is actually facing backwards. The third one, there seems to be an inferior subluxation with the GT fracture. Although overall, if you want to say things could be, it is undisplaced or minimally displaced rather. In type 4, we can clearly see one big spike, something looks like a head split over there. And in the last one, we can actually see the traditional fracture dislocation. Now, the original fracture dislocations were meant for these, that you have a shoulder dislocation along with a small fracture. The small fracture is usually a GT fracture because the shoulder dislocation is anterior. Now, mind you, whenever you have an anterior dislocation, the GT fractures because GT is mostly a posterior-based fracture. I'm not saying that in all anterior dislocations, GT has to fracture. Mostly, if there is a fracture in a anterior dislocation, it is a GT, and vice versa. It's a posterior dislocation. LT is what is fractured because LT is an anterior structure. If the shoulder has to go backwards, the opposite side restraint should be broken, right? So if the shoulder has to come forwards, the posterior restraint is broken, which is the GT. If the shoulder has to go backwards, the anterior restraint is broken, which is the LT. And that's the usual common scenario. And the term fracture dislocations were originally reserved for these injuries, that you have a shoulder dislocation, which is the bigger element, and then you have a small fracture, which could be of the GT or which could be of the LT, depending on anterior or posterior dislocation. But over a period of time, almost all of these, rather all of these started to be labeled as fracture dislocation. And then if we try to search literature to see what to do for fracture dislocations, we get a confusing scenario, right? And we'll understand what the confusion is also. That's why it's very important to know when you're telling of fracture dislocation as to what entity are we talking of. We are talking of a complete fracture, multiple fractures, and a dislocated head, or are we talking of the simplest one, which is the typical fracture dislocation? So typically, what do we do? I mean, the patient comes with the history of fall or history of road traffic accident. The patient will complain of pain. There'll be tenderness in and around the shoulder, and the patient typically complains that it's difficult for him to move the shoulder. Okay. What will be obvious if there is a dislocation is that there will be a loss of deltoid contour. Okay, now again, mind you, this is with regards to an anterior dislocation. A posterior dislocated shoulder, the signs may be very subtle. We will not be able to appreciate it much because the deltoid contour is not lost. Now, in anterior dislocation, the deltoid contour could be lost. Okay, and it's not neuromuscular, it's neurovascular examination is very, very critical, because many of these dislocations can have either the vessel or the nerve, or sometimes combined injury of both of these, and it's often missed out, right? Because it becomes so obvious it is dislocation, we do not tend to think. Now, mind you, a shoulder is a structure, a joint rather, there are a lot of structures in and around this. Now, if you could see the axillary nerve, which is in green, it is so close to think. Now, this is when you're being from the back. Okay, so when you have an anterior dislocation, obviously you can expect some stretching of the nerve. Okay, the axillary nerve, that is the nerve which is at risk for dislocations. And of course, the vessel also is very close, axillary artery or the brachial artery, and even those could be injured. Okay, so axillary nerve, how do you check? It's very difficult to check the motor component of axillary nerve, especially in a dislocated and a fractured shoulder. But what we need to fall back on is the sensory component. So as we can see, what is called the regimental badge sign. So that area over the proximal part of the arm. Okay, so the soldiers on the sleeves, they wear their badge. So that's the regimental badge sign. So on that area, you could just check for hypoesthesia. So even in a fractured and dislocated limb, the patient should be able to tell whether it looks hypoaesthetic. And if that is the case, we have to start thinking that there is an axillary nerve injury and can warn the patient, also document. Now, all of these are very critical because if we do not do that, after a reduction or after a surgery, the patient can start complaining that this was done as an after effect of the treatment and not because of the injury, right? So it's always to be safe, we need to do a thorough clinical examination. Also, whenever now, as a matter of fact, in any of the fractures or any of the dislocations, we need to look into distal vascularity. That's it's by protocol we need to be doing that whether the vessels are intact or not. But if you see such an injury where the shaft is medialized, now if you look into this, the shaft has a significant medial spike on the medial side. It's a very sharp end point, and that is significantly medialized, right? Now, if you see such an injury, you have to be doubly sure whether the artery is in place or not. What may also happen is there could be a such significant intimal tear leading to a delayed thrombus. Okay, now this spike can hit the vessel and come back, leading to a delayed thrombus. So you should always keep a watch. So, in fact, there are recommendations now that if there's any doubt or for such nasty injuries where the shaft has been medialized with a big spike, always get a CT angio. Now, if you could look into this, although the artery is intact, but there is some damage caused because of the diaphysis into the axillary artery. Now, this can lead to a pseudoaneurysm over a period of time, or it could even lead to a delayed thrombus. We need to keep a watch out for. Okay, so that's two things. Always remember: look out for nerve injury, look out for artery injury. Artery injury may require a CT angio if you're suspecting. There is no harm because this particular thing is that close lying to the artery that even during reduction, whether closed or with an open method, we can damage the arteries. Okay, so even as a knowledge, we need to realize how close the artery is to the medialized shaft, and need to take care when you're reducing this introp. Okay.